Alrighty, city manager reports.
There's been some publicity recently about, up in Tulsa, some billing issues regarding DEMS, and I've asked Steve Williamson to come this morning to talk about that. There's also a report, a city manager report in your memo of some observations by my staff on the issue, but Steve?
While Frank's getting set up, I just wanted to agree with Dr. Shadid about the importance, and also it isn't just those who are addicted now. I broke a 5-generational addiction issue in my family when I went into recovery 10 years ago. So it also helps future generations for that decision. We're going to discuss, as you know, a lawsuit was filed, and so I can't discuss the specifics of that, but I can go over generally some of the misconceptions. And briefly, I'd like to discuss the misconceptions that we weren't going to file for insurance, that we charge people for out-of-pocket expense who are a member of the Total Care Program, and the use of liens and small claims court, what purpose that is. The background in this was the authority looked at ways because both beneficiary jurisdictions, there was stress on general fund. We looked at the fact that baby boomers were coming on, 10,000 people a day are turning 65. So more and more people are going to be covered under Medicare. That's also the age in which transports increased due to chronic illness. We were looking for to augment the costs that Medicare and Medicaid doesn't pay, how to help the citizens with that. And then also the other reimbursements that were anticipated in the American Health Plan, which would also be reimbursed at below cost. The next slide demonstrates the program. It has always been a factor of the program to charge or bill any third-party payers the patient might have if they are a subscriber. The necessity for that, on your left-hand side, I want to address that bar chart. When you see that, for example, in the West, the expenses are $34 million, where we recovered the revenue to match that expense, you see that we had $10 million from Medicare, 4.6 from Medicaid, $9 million from private insurance, private pay, those without any insurance was 1.8, the utility fee was 7.1, and the non-beneficiary jurisdictions is 1.8. If we weren't billing third-party payers for services that the patient has paid his insurance to cover, there is no way we can meet the budgetary requirements on what we bring in from the utility fund. So it's always been a function for this to work and to keep the $3.65 as low as possible to bill third parties. Also, that helps cover, which I'll show later, the large number of people that we cover that have no insurance at all, no ability to pay. Go back one more, please. There was issues about the 60-day requirement. In your packet, you'll also see an annual review of how the terminology changed. It has always been a function of the program that if you didn't turn in the insurance information so we could bill, you could be terminated from the program. In 2008, we made a change to that same section to widen, we made the less exclusions to who a member was in a household because we were now doing it on the utility bills, so we made it less restrictive. It was those living at that address, so we covered more people with it. 2009, we didn't make any changes. 2010, now these changes happen every year after the program. We go back and we look and see what are the phone calls about? What were the questions asked? And all we did was, does the type need to be bigger? So these are all just little changes that were made. It didn't change anything in the program. It was just to make it clearer in our written communications. It was asked, well, how much time do I have to get that insurance information in? We initially put 30 days, but we realized that sometimes the person in charge of getting the insurance information to us might be the one sick. So we increased that to 60 days the following year. Why is it important to put a time limit on it? Well, it's an inducement to get the information in, but it's also a very practical one, a financial one, is that many insurance companies have a timely filing deadline. And if you don't file the account within 120 days, then it's denied when you do file it. So it's imperative for us to capture that on a timely fashion so we can file the claim in a timely manner. So that's the whole deal of the reason for us trying to make that as clear as possible. And the days was put in there as an inducement to get it in.
May I interrupt you, Steve, and ask a question? On your third-party payments, I think that's important. But if somebody was a subscriber to the system who didn't have insurance of any kind at all, he was not Medicare eligible, he had no private insurance, what would the system pay for that ambulance ride for?
Everything.
Okay, that's what I thought.
And we'll get to the magnitude of that in just a second. There's a lot of billing requirements that are due to federal funding of the Medicare program. There was some question why on non-emergencies, if Medicare denies the claim, they only got a 40% discount. And that's because of Medicare regulations. We had to put that in. So we weren't showing that we were using the subscription program is an inducement for unnecessary trips. And that was a federal requirement put into these type programs. But on all emergencies, it covers everything. And that's always been in the program and recognized. The program itself has been very successful. If you look at the
Steve, I'm sorry to interrupt. Just going back to that on the 60-day, I mean, one thing that was pointed out is, was the 60-day policy approved by the board, or how did that come about?
No, I changed. We had in our annual meetings the tweaking of putting in 30 when there was nothing, or the 60 when it was 30, was done by staff.
Okay.
It wasn't a change in the program at all. It was just to make it more understandable to the public.
But that part was never approved by the board?
The 30 or 60 days?
Right.
No, it wasn't.
Okay.
If you look at the maps in there, the first map indicates in year 2011, by zip code, the amount of people that had partial or their entire bills taken care of by the program. So you can see that there is wide distribution across the city of people who benefited from the program. And that total for that year was 11,164 individuals had partial or their entire account taken care of by the utility program. That amounted, that's the second map, to $5,729,000 was handled through the utility program. Interesting number to show how beneficial this is for a lot of people. Of that 11,000 that were handled through the program, 3,700 had no insurance at all. To answer your question, Councilor Ryan, 3,700 people of the 11,000 had no coverage at all in this.
And they were not charged anything for it?
No, sir.
In reference to the encoding of individuals and the address, do your program have the individuals who are registered with the program, are they encoded in a way in which when you get a call to that particular address, that it's not an issue as to whether or not you have to wait for them to provide what medical information or insurance they have?
Okay. To answer your question, we get a database from the city once a month of those who are paying for the program. And one thing that's different about this than Total Care, when we had the Total Care program, you filled out a form, you got a card back, and we got all that medical information up front. Now, since it's citywide, we have to get it after the fact. So each run is compared to the database of the jurisdiction for which you live to see if you're covered or not. Then we seek the information.
So you will always have to inquire of the patient to provide information to you, even though they are in the program.
Right, unless, yes. Because there's no way of us, when it's citywide, to get everybody's insurance information beforehand. Now, we check it, a lot of people's insurance changes from year to year. If they were transported by us before, we re-verify the coverage. If they respond to us when we seek their information, we verify what we had from the last trip.
Steve, excuse me, may I ask a couple of questions? With respect to billing somebody, if you have a situation where you have a couple living, husband and wife, living together, both of them are covered by the program if they have their fees paid through the utility arrangement. I had a question posed to me a week or so ago concerning a situation where the husband has passed away. The wife is still alive and it continues to be a part of the plan, but she had a concern whether or not she would be covered because the utility bills, for example, are still in the husband's name.
No, it's address dependent.
Okay.
And that's another complexity of it because, for example, rental homes, it might be in the owner of the home named the TAP, but it's being paid. So it's whoever lives at that covered residence.
And people who do rent have the option of participating in it. They have to go through some other means if
Yes,
they're not paying the utilities.
If the traditional Total Care program we had in the past where you pay the one fee and it covers, we offer that for those that live in multifamily dwellings that opted out, nursing homes. And so there's both avenues to get to the one program.
And then the final question is, somebody who is currently under Medicare, there is an advantage to sign up for the program. Will Medicare pay for the entire cost of an emergency transport?
There are, no, there's
Okay.
a copay there, and if they don't have a secondary policy to cover that. Also, on emergencies, sometimes they are denied,
I see.
even though when you would think it would be covered.
But by signing up, they would also be covered under a non-emergency transport if that was necessary.
That's correct.
Okay, thank you.
There was also some question in the paper about the liens that we file, and it's a little bit misrepresented. On automobile accidents, there has always been a tool for hospitals and physicians to file a lien on proceeds. And about 10 years ago, we were successful in the legislature to have the same type of lien written in the law for ambulance services. So an automobile accident, we place a lien on proceeds, and we have to name the patient and the insurance company. What that entitles us to is that our name is on the check then. It has nothing to do with the property. It doesn't affect the credit rating. It doesn't affect your ability to sell the home or anything on your mortgage. It simply allows us to have our name added to the proceeds of the settlement on that case.
And that was one of the questions that I had asked staff some time ago. The person that is being transported and they are in the program, they're involved in an automobile accident. The automobile accident is no fault of theirs. The other party has insurance, and at some point in time, there's a lien filed from IMSA against the proceeds. The fact that that individual is in the program, do any of the payments that they have as far as being in the program, do it offset any of the cost of the transport because you filed a lien against the proceeds?
Yeah, just
So are you
as,
saying that all the proceeds from those proceeds, that the total amount of the bill has to be paid, or the fact that the individual is in the program, do they get any of that paid from the fact that they're in the program?
if there was absolutely no settlements on either side, the membership would have covered the account. But if there were proceeds paid for medical services to include the ambulance service, then that is the portion that our lien would go against.
Well, my question is then, the fact that the individual is in the program, is any the funds offset because of the enrollment in the program?
Yes, we would only seek and would only receive what was paid by the insurance carrier for his medical bills, which would include our bill.
But if they're in the program, they shouldn't be billed, right?
He's not asked,
Well, it's...
are you addressing this or a different?
Yeah, what Skip's bringing up. I mean, if you're filing a lien on somebody who's enrolled in the program, you're going to make the
I'm filing
other insurance carrier believe that they owe for ambulance services when in fact they don't.
No, they do. They do. Just like we said earlier, all third-party payers are sought after, but the patient isn't responsible for any out-of-pocket expense.
Okay, but oftentimes there's not enough money to go around to pay all the bills, and
Right,
so
and we work with them individually on that, just like the hospitals do and just like physicians do. No different. The $3.65 isn't going to pay for an ambulance trip by itself.
yeah, but I mean that's true whether you're in an MVA or just in a house. I mean it's no different for an MVA.
Well, but there's funds paid by the insurance carrier for medical bills. And it is our job to capture as much of that revenue as possible so we can cover all those who have nothing and to keep the monthly fee as low as possible.
But so on the liens for an MVA, how much are you discounting that? Are you trying to collect the full amount, the $1,100?
We try to. If they don't pay that, then we take what they pay.
My concern...
That's a standard way of doing it, though. I mean, I've settled claims. I've settled claims before as an attorney, and there's a claim by the hospital in there for whatever it was. Most of the time, the hospital claims are so huge that you can sit down with the hospital and negotiate something less than that. But I've done that when people had their own health insurance, the ambulance insurance. The other company had insurance, they had uninsured motorists, they had every kind of insurance you can imagine, but the hospital still wants to be paid. So I don't think that's unusual. It seems to me that's the way every carrier, hospitals, doctors do it, chiropractors do it, physical therapists do it. I think that's pretty standard.
But Pete, just from a layperson's perspective, it doesn't seem fair if they've been a subscriber to the service and they were to receive some kind of an award for the fact that they've been injured, that a part of that award would then go to IMSA. Just from a layperson's perspective, maybe that's the way the law operates, and if that's the way it is, that's the way it is.
I don't know why they would be more upset about IMSA than they would be Integris or...
Well, the point in, again,
Indeed,
just
or-
from a layperson who doesn't follow this that closely, if I signed up and paid a monthly fee, I would assume that that covered the cost of transportation. And then, after an award had been obtained by me due to injuries, that someone took a part of that. That's the part that just doesn't seem fair if I had been paying into the system.
But David, I think what we're hearing here and what should be very clear is that what you're paying for with that 365 is your portion of the cost of that transport.
That's
not like
the
an
total,
insurance
it's not
policy.
the total cost. You, typically, an individual who is insured is going to have their insurance carrier pay and be billed for the bulk of the transport.
The copay and deductibles or any other out-of-pocket expense after any third party is sought is forgiven. So it's a huge benefit for the $3.50 you pay.
Oh, I agree. I think it's a good bargain. I would recommend everybody sign up for IMSA Care. I'm just saying, I looked at it as almost like paying into insurance. For example, I pay X number of dollars a month for insurance, thinking that if I ever have a serious operation, the insurance company is going to come in and pay for that instead of me having to come up with all of that money. And if I never have that operation or problem, I've just paid into this insurance company and they've made some money off of me. That's why I kind of look at this IMSA monthly
This is not
bill.
any different than that.
Well, but,
It's not any
okay,
different.
I guess I just need to focus on it.
Yeah.
But if you have insurance and you're paying into your insurance company, you're still going to have a co-payment that you're going to have to pay out of your own pocket. An insurance company typically doesn't pay 100%.
Okay, I agree.
this
Excuse me,
covers
I'm
that
sorry, I didn't mean to bring this up. I'm just saying.
Unless you have a secondary. So explain to me, if somebody has Medicare and then they have a secondary, right, that would pick up their copayment.
Or
What
they haven't met their deductible.
Okay, but let's say they've met their they've got Medicare, they've got a secondary. What does enrolling in the utility program get them?
If it's denied, it would take care of it on the emergency side. For example, you go into the emergency room for a broken hip, or you fall, and we take you in to rule out a broken hip. Then we take you home. They only pay for the going to the hospital, not the home. Certain circumstances like that is where it would help. And we tell people, and we counsel them when they call, when they ask should they get it, if they feel comfortable that that both policies that they cover are going to pay for it, then they need to look at it. But there's always deductibles and copays, to deal with, and denials. So, that's correct.
They're not billed the copay. They're not billed the shortage. They're not balance billed. They don't pay anything.
No.
I'm just not sure that our senior citizen would have any chance of understanding this, but B, if they had Medicare and they had secondary, that they're really getting anything for.
I disagree. And if you look at who buys it.
How many times are you taking people back home from the emergency room because they didn't have a broken hip?
Pardon me?
I mean, how often does that example?
That particular example happens all the time.
Okay.
All the time. It's one of the ones we take the heat for Medicare denying it. They can't understand why going it was covered and coming home it's not. But that's the rules.
What steps are being taken to try and figure out how many people have paid that were actually enrolled in the program? What are we doing now that this has come out that some people have paid?
Well,
How are we going back over the last 3 years to identify those who erroneously paid?
Well, first of all, we don't feel like that many erroneously paid. But
How do you know that, though?
Because we've looked at the account. I can't discuss those issues till after the
Lawsuit.
case. Yes. And as a trustee, on the trust, I have updated you on a weekly basis about where we are and what's going on with that. And as soon as we can, we'll address more.
Skip, did you have a question?
You have had some people to opt out of the program that enrolled in the program, then opt out of the program. From Tulsa and Oklahoma City, the two major metropolitan areas, what has been the percentage of individuals who opt out of the program last year in Tulsa and Oklahoma City?
It's very low. The difference is about plus or minus 2 or 3% from the year before. Oklahoma City has been about 3% less than Tulsa, and Tulsa's about 90% opted in. Oklahoma City is a little bit, it's in the high 80s that are opted in.
Would some of the opt-out, would it be attributed to the fact that you have apartment complexes who enroll and then opt out?
That's correct.
Which affects a large number of people in the
Councilor
complex?
Kelly, that's a real problem for us because they don't let the tenants know that they've changed. And we're trying to find ways to address how they should let the tenant know. Some of the confusion that was some of the calls that we received, and we didn't receive, with all this press, our phone numbers have been in there and nothing has cropped up. The average calls are 20 a day more, and they are like 90, we've kept records of those. It's like 98% of those are checking to be sure we show them as in. We haven't had, we've found one refund that we've made that was in the paper. Keeping in mind that we transport 120,000 plus people a year and 20-some thousand a year use it, we think our checks and balances are pretty good.
Anybody else? Gary?
Well, I just want to remind people out there that I haven't heard anything in the press that's new. I mean, yeah, if there's been some people that have been misidentified and they were billed when they shouldn't have, and we sent bill collectors after them when we shouldn't have, and all of that, and I think Steve and his staff worked through those issues, and if it's truly legitimate and it gets taken away and all that kind of stuff. But you got to understand that this is an emergency medical service that we're providing, and it's under the same, if you think federal regulations on minor issues are complicated and change all the time, you ought to delve into Medicare and Medicaid, especially when it comes to billing on emergency runs. You'd be surprised how many times Steve's staff has to argue and re-argue and re-argue with Medicare that it was truly an emergency call. Because at some point, if Medicare says that wasn't an emergency, they just had the flu, they could have driven themselves to the hospital, then if we don't get reimbursed for it, there you are. And the utility fee was simply a way to create revenue and put people in the total care program versus general revenue fund subsidizing IMSA in the Western Division for years. We've been dealing with the same kind of billing issues and the same kind of collection issues for years when we were just subsidizing it out of the general fund. The billing utility fee issue came up as a way to create that revenue and give people the benefit of being on total care if they want to pay that bill. If you think you want to pay 100% of an emergency ambulance service in this city for all citizens, regardless of what they have, then I think you don't want to know what that tax charge would be, what it would cost to do that annually. So all of these issues are all of the procedures, all of the billing, all of the collections, all of the private insurance, Medicare, co-pays, all of that is the same as it's always been. It hasn't just cropped up because of the utility fee has started paying for those people that participate in the program. So should we stay on top of people that have a legitimate claim that they were in the billing program and they shouldn't have been received a bill? Yes, very much so. And if brought to our attention, should we deal with that? Yes. But to say that this system is broken all of a sudden, either because of the utility fee or something new has happened at IMSA, I think is totally incorrect, and I don't think the public should be given that perspective of the program.
Your Honor, I want to comment on, I think Gary's right on. One point that's really important is when you have a system designed by humans, maintained by humans, occasionally when you're dealing with 100,000 plus accounts, you're going to have a mistake made. It's unavoidable. I would guarantee that any system that administers a program to this number of customers is going to have a mistake. And an old line foreman once told me that, Sonny boy, it's not the mistake, it's how quickly you recover. And that's what we need to judge IMSA on. If they do make a mistake, are they prompt in dealing with it? And do they deal with it fairly so that the individual who is involved understands the process? That's what we have to focus on. Not that occasionally we're going to have mistakes made. That's going to happen. It's unfortunate, but I'll guarantee. I've worked for a company that maintained thousands of accounts, and despite our best efforts, occasionally we blew one. But and we're going to make a mistake, but the important thing is how quickly our processes will allow us to deal with that mistake, and if we did make a mistake, correct it. So I think Gary was exactly right. This is going to happen.
We're the first to offer this to a metropolitan area like this. So we're also using different tools that weren't necessarily designed to do this. So we're having to be look at many different checks and balances to use the tools we have. You know, it'd be a lot better. The first thing you do when you go to a doctor's office or to any medical facility is the first 15 minutes you're filling out the information beforehand. You know, we don't have that luxury, so we have to do it after the fact. So there's a lot of complications, and we just have to be diligent and have the policy, have the procedures and the process to look at issues and fix them. Yes.
Steve, one of the things that we've done this morning is we've been just focusing in on the administrative side, what I'm calling it, or the billing and collection side. We are not focusing in on the level of service, the outcomes from the medical people that we have to pick, or the people that we pick up in those emergency situations and have to transport them and administer emergency medical care on the way to the hospital. And you have a couple of reports that I have seen no publicity on that your medical control board director, Dr. Goodlow, has come out with that points about the quality of the service. And so I think the public needs to be aware of that. And then there's another component here. If I have a heart attack and I need to be transported to the hospital and I recover from that and I begin to get bills in, I have the responsibility as a consumer of that service to read the bills that come in and to provide the documentation to whomever, doctor, hospital, therapist, IMSA, to straighten out my account so that we can go forward. And I think that's the missing component that has not been really publicized. That we all have responsibility of consumers of this emergency medical service to make sure our bills are taken care of in an accurate way.
We welcome any call that you might have in reference to the way that count. We're looking at how all the paper reads. We do that every year. That's when we added the numbers or changed the type or look at how it's laid out. But we welcome the phone calls.
Steve, thank you very much for being here.
Well, I want to just say one more thing. I think that, I just remind that when we talked about whether the city should take this over or IMSA, I mean, we were really lectured about how the expertise of the billing department at IMSA and how, it would be really almost impossible for the city to match that. We now have a class action lawsuit against, based on billing practices. We know in medicine, as you know, lawsuits, a large percent of the time is when there's poor communication. It comes down to communication. And that's, I think there's a pretty clear consensus with the mayor of Tulsa coming down, with all the city council in Tulsa. There's a consensus that communication is poor. I mean, that people were harassed, that there's some communication breakdowns. Even you may make mistakes, but it's how you deal with those mistakes. And that in medicine, that's oftentimes who gets sued and who doesn't sue. I mean, complications happen all the time. but the doctor with the poor bedside manner, and who just, I mean, that's the one that gets sued. So you're right, it is how you deal with it, but there's some communication problems here, I think. I don't know, you may say that you don't know that it's broken, but I don't know that we know at this point in time that it's fixed or working either. I don't know that we know the scope of how many people paid their utility fee but erroneously were charged and just went ahead and paid. I mean, right now we're looking at 1,100 lawsuits since 2009, right, that have been filed. So we're focusing on those 1,100 people that Works and Lentz filed to try and collect funds. 1,100 lawsuits in 3 years. That's like, what, 30 a month against patients? We don't know at this point in time how many people were opted in the program but actually paid. We just don't know the scope of the problem at this point.
Well, I think there's even checks and balances in that. We didn't lose one of those cases. The judge didn't see where we were unjustly.
I mean, you dismissed it. I mean, you garnished,
we dismissed
you garnished
too.
wages on somebody in Jinx, and in Jinx, you don't even have the option of opting out. Everybody's in automatically,
Yeah,
and they garnish wages on a patient.
You heard one side of that story, and that one was an error. You're assuming everything you've read is absolutely the way it is, and I mentioned earlier I can't discuss those till after we file our response.
Okay. Well, we'll talk in executive session then.
Thank you very much,
You're
Steve,
welcome.
for coming down. We appreciate it. No, this is a complicated subject.